Good afternoon, everybody. I strongly believe that who stays in the room will be qualified as a hero of public health in Europe. I didn't check, what is the today attraction in Brussels, but the city is full of attraction, not just Meneki Peace, but a few others. So let's start our session. My name is Andrzej Ryś. I'm Director for Health Systems and Product, European Commission. It's a pleasure to chair this meeting. I will go introduce my colleagues who join me here today. Professor Jean Bosquet from Montpellier, from Languedoc-Roussillon region, and our second speaker of today is Professor Bernadette Hannigan, who is representing Northern Ireland region and Department of Health, Social Services and Public Safety of Northern Ireland. Before I ask for presentation, just a few points from my side. You have a chance to hear my commissioner when he spoke Thursday in the opening about investing in health. This was really an important piece of our work this year, and I strongly believe we were able to push some debate around this topic, not just in the European Commission, but also across Europe. The financial crisis trigger all kinds of debates, but also trigger the huge question of how much we are able to respond to this crisis, but also the crisis show that those they're able to respond. They're also looking for the new tools, new ideas, and challenges we are facing in Europe since years, like aging, chronic disease, patients' involvement, demand for new treatment, for new technologies. They don't go away, they stay with us. Of course, it's interesting to see how those response can be built together. So when we discuss investing in health, we thought that it would be important to look on innovation and knowledge sharing, human and social capital development. So this led us to the important initiatives which was developed by European Commission, called European Innovation Partnership on Active and Healthy Aging. As you recall, the active healthy aging is one of the objectives of our health strategy from 2008, and will continue. As again, Europe is aging, and is continent is aging the fastest in the world, and it will be interesting also to learn, how regions and local governments are responding to those challenges. So we established this tool. There was call for reference site. What is important, those sites were evaluating among themselves. So we have this maximum 4 stars. The good news and bad news is that no one site got 4 stars. The good news is that still work to be done, and but I think it's important to also say that those sites were selected very rigorously, and I think this peer review process or peer-to-peer review process was quite interesting. Maybe we can also learn from our speakers how they see this exercise. So go to innovations, because we have authors, we have those they are really doing things on the sides in practice. So if I may ask Jean, you first go and speak. Sorry. No, because now we are having some technical challenges, innovation. So we swap. So Bernadette will start with her bit from North Ireland. We are in green already on the picture. So please, so we travel to Northern Ireland.
Okay. Thank you. And good afternoon, everybody, and thank you to the organisers for inviting me to speak about our participation as a region within the European Innovation Partnership. I think, first of all, it might be useful to explain how the health system of the United Kingdom currently operates. Because from the past few years, what we have had is 4 completely separate systems. So funding for each government department is decided in England, and then funding is allocated to the other countries, Scotland, Wales, and Northern Ireland, in proportion to our population. Now, this leaves each region free to decide exactly how it wants to organize its services. It means that we have now a situation in the UK where we have really evolved 4 separate systems that are becoming more and more different and more separate. I mean, one of the big driving factors would be, for example, the differential in size. England has a population of almost 60 million, and as you will see, in Northern Ireland, we are very much smaller. So one size cannot possibly fit all, but also we have other issues to deal with. So the focus of the Innovation Partnership on activities and actions in regions is really welcoming, and we certainly find it very empowering to participate in our own right rather than as just one part of a member state. So this is the slide that I call the more slide. We don't need to go into a lot of detail, but it just shows, like so many other places we've spoken about this week, more people, more years, more illness, more requirement for service, multiple morbidities. The more of those illnesses you have, the greater is your demand on services. So we have more everything, except we certainly do not have more money. Because of the situation that I have indicated, that we are allocated a fixed budget, so therefore the funding we get is irrelevant to what is our local GDP, and we do not have tax-raising powers. So the money we get is it. Little more on our demographics. We have the fastest growing population across the UK. Obviously, good things like life expectancy increasing. Of our 1.8, just over 1.8 million people now, we have 1/5 under 16 and slightly less than that aged over 65. But the number of people over 75 will increase significantly, and even over 85 will again increase even faster by 2020. And of course, by that time, we will have higher expectations, even further advances in technologies, greater IT use by all ages, and of course, the ongoing pressure, or the ongoing need to reduce pressure on acute care services. So, our chronic disease challenge. Northern Ireland gets a total of £9 billion every year, and of that, our health and social care budget currently costs over £4.3 billion, so almost half of everything we get, and that is due to rise further. So the only pressure on our funding is downwards. So of the 2/3 of the over 75 have 60% of all the visits to GPs, 72% of the acute bed days, and 69% of the social care spend. So we've an increasing focus on people's well-being, of course, by preventing poor health, but also by reducing inequalities. I'm going to look at some of those inequalities for a moment. And looking at, first of all, the gaps in life expectancy. So looking at contrasting our most deprived areas with our least deprived. So males in the 10% of the least deprived areas live on average 12 years longer than those in the most deprived areas. The cancer-related mortality is doubled in the most deprived areas. The smoking-related causes is 4 times higher. Alcohol-related mortality, 9 times higher. Drug-related deaths, 11 times higher. Also, suicide is about 5 times more frequent in the more deprived communities, and we have a high level of teenage births in those areas as well. So a focus on aging and the needs of the aging population in general cannot be the sole focus. We must address these inequalities. And that is just showing the same thing, that really for all causes we have a discrepancy between different areas. And sometimes the areas where people live are really close together. The Chief Medical Officer's report last year showed the statistics along just one single bus line in Belfast, where the full spectrum of differential expectations was visible. And we have an issue with obesity and overweight. So in some age groups, over a third of people are obese or overweight. So these issues can be brought together into an increasing problem. The growing population, poorer health, growth in chronic conditions bring about instabilities in our health and social care system. And I should say that the health and social care are completely integrated, single system, organizations responsible for all those services. So therefore, change can happen in a completely unplanned and haphazard way. Poorer care and treatment, poorer health outcomes, and an inability to address the future needs. We need something radically different. So if we continue on with the usual care, so it's the pink part of the diagram there, the cost of delivering the care will go upwards for the people in those age groups, 55, 60 plus. Whereas if we could move to a more preventive focus on health and well-being, then can change, reduce that level of total spend, but address issues of premature mortality. The various organizations were changed some 4 years ago, such that now we have one single department with responsibility, so as I mentioned, spending half of all the public sector funding, organized into 5 trusts that include acute hospitals and all of the other elements that make up a social care service, but primary care practices are separate. But also creation of a public health agency and a commissioning body. So the commissioning body, the Health and Social Care Board, listens to the voice of local commissioning groups to commission or pay for services, but the public health agency works alongside them so that public health initiatives can also be funded. The focus of the Public Health Agency is protection and health improvement, promoting well-being, reducing inequalities. A particular feature of the way it works is through partnership. Partnership throughout all of society with communities, education providers, housing organizations, with others responsible for economic and social development, and with local government. Communication initiatives are very important, and finding ways to support behavior change. So there are over 700 currently funded initiatives, so interventions with that endeavour to integrate seamlessly into people's ordinary lives. Importantly, we're doing what we can to embed evaluation and research into everything that happens in each initiative. And so we also have a Centre of Excellence for Public Health in Northern Ireland. And that is one of 5 such centres throughout the UK that each has developed special areas of focus. One in England focuses on exercise particularly, another one in England focuses on tobacco, for example. Northern Ireland tends to have a predominant focus on dietary matters and increasingly on mental health issues. Two major strategic plans. One is a public health strategy, Fit and Well, and it's a 10-year whole system life course approach. So building sustainability within communities, building up social capital, and recognizing that health and well-being are not only the responsibility of a health department, so the metrics for success to track progress against Fit and Well belong to many of the other government departments. And secondly, a major transformation initiative, Transforming Your Care, to improve population health status, reduce avoidable demand on service, and modernize care services. So Transforming Your Care is based upon 12 principles, largely focusing care around individuals, using outcomes to shape services, right care at the right time, focusing on the needs of population and on prevention, integrated care, working together, promoting independence and personalization of care, safeguarding vulnerable people, ensuring sustainability of services, value for money, maximizing use of technology, and incentivizing local level innovation with, of course, evaluation. So those of you who are familiar with the European Innovation Platform on Active and Healthy Aging will know that that has defined a triple win. That is, it wants to have better health outcomes, wants to promote economic development, and wants to promote the sustainability of health and care services. So under its overall banner of adding 2 healthy life years on average to people who are born by 2020, there is that triple win. And that aligns perfectly, as I say, with our transformation strategy. You heard from our chairman about how the reference site process, so Northern Ireland submitted evidence in 3 areas which led to the 3-star award. And the 3 areas we focused on were integrated medicines management, integrated long-term conditions management, and citizen-centred health and social care. To speak a little about all 3, the kind of activities in integrated medicines management are very broad, and this is our most developed of all of the 3 areas. And the STAR award system actually was based on the highest score that you get from each of the submissions made from any region. And so our medicines management scored 3-star, and so the region as a whole becomes 3-star. So this is both innovative services in secondary care and in primary care, in the interface between the two. Importantly, based frequently on novel IT systems, some of which have been developed in association with indigenous new ICT companies, so hence the economic development aspect. Some of the high-level outcomes, reducing lengths of hospital stay and increasing the time to readmission. So particular focus in the work of understanding the origins of and reducing the incidence of healthcare-associated infections, and of course within that, proper antibiotic stewardship. So one example of an activity is nursing home outreach clinics, where consultant pharmacist and geriatrician working together to visit each of the care homes and working with local primary care, reviewing the medicines for each of the care home residents and intervening to reduce the level of polypharmacy. Around integrated long-term conditions management, using technology probably is the most significant intervention here and delivering care closer to people's homes. So I know that there are such technological initiatives in many, many regions around the EU. We can see that we're beginning to have an impact on the inequalities because the UK has a quality outcomes framework which demonstrates that primary care in Northern Ireland is achieving better outcomes for heart disease. The remote telemonitoring Northern Ireland, we're currently commissioning an evaluation of its contribution to improved outcomes, but particularly focusing on the use of routinely collected population-wide data. And finally, citizen-centred health and social care, valuing older people and focusing on their quality of life. And the main driver of what happens is a single assessment tool. So every person aged 65 or over who comes to secondary care has this overall assessment undertaken, and their needs then are communicated to whichever group or professional grouping or organisation is responsible for delivering that particular service. So the staff who are within the services have a greater understanding both of their roles and the roles of their colleagues. And of course, there is more efficient sharing of information. And new consultative fora have been established that actually listen better to the voices of older people. So what we're trying to do now with our research community is to get the researchers to work more closely with the services and organisations who are delivering initiatives in these three areas, both to undertake evaluations, but also action research and new parts of the initiatives. And so they will hopefully develop consortia and bids to Horizon programs. To address something that the speaker in the previous session spoke about, which is getting the outcomes of research really used better in practice, the teams that we want to create really should always have members of staff and patients involved in the research consortia in addition to researchers. But for health and care organisations, this is a challenge, principally because the staff involved obviously don't have time for research built into their contracts. But secondly, those organisations do not have a track record of experience or understanding of how to do the costing and administration that is necessary for participation in EU programmes. So this is an education and experiential program that we are trying to develop so that the actual organizations that deliver the innovative services can be research participants. So as a reference site, the idea is that people from other regions who are participating in the innovation platform will visit and learn about and help us learn further about what we're doing. So whether you're interested in our historical architecture, the wild countryside or the golf courses, or the sites that are used for the filming of the TV series Game of Thrones, come and see us, see those things, and help us to develop our innovative services. Thank you.
Thank you very much, Bernadette. And now we can swiftly move to the next presentation by Professor Jean Bousquet. I would like still to have a few minutes for discussion because I know that we are going to the end of this conference, so we should keep our time as good as possible. So, Jean, over to you.
Thank you. Mr. Chairman, ladies and gentlemen, I would like to tell you what our region is interested in. I'm from the Région Languedoc-Roussillon, which is in the Mediterranean coast of France. In fact, what I've thought for many years, it is that we would like to have a systems approach in multifactorial chronic disease with comorbidities. Why? Because number one, we spend 60 to 75% on healthcare due to these diseases. Second, they are going across the life cycle and we should not focus only on healthy aging, but we should focus on very early stages. Thirdly, because we have a potent research group in our area, and then that we can make a program which is a holistic program. So, first of all, what do we speak about chronic diseases? Well, they are very diverse, from infectious with pathogen, host, and infectious diseases, to genetic diseases. Now, cystic fibrosis is a disease of adults. It has become a chronic disease, but mainly with lifestyle and also environment, because we have risk and protective factors which are extremely important. These include tobacco smoking, pollutants, allergens, nutrition, infections, physical exercise. However, the picture would not be sufficient if we didn't ask socioeconomic determinants and aging. So to tackle chronic diseases is not only to go to the aging population, but to do more. If we speak about numbers, WHO has estimated, because it's just an estimation, that chronic diseases in red and pink represent the most common diseases across the world, except possibly in the WHO region for Africa. However, in Europe, underlined, more than 85% of diseases or deaths are due to chronic diseases. The important point is that common risk factors are inducing major chronic diseases. You have cardiovascular disease, diabetes, cancer, chronic respiratory diseases. And then tobacco use for all, unhealthy diet, physical inactivity, harmful use of alcohol, and biomass fuel combustion. So when a patient has one disease, probably the patient gets more. And in this remarkable study from Scotland, published on 1.7 million people, it is shown that according to age, from 0 to 85, you have an increasing number of disease, and then you may have up to 8 diseases. So if you want to tackle cardiovascular disease in a patient, probably you need to assess chronic respiratory disease and metabolic diseases. And this is very important and possibly needs to be done before the elderly. The same study showed a very interesting issue. It is that not only chronic disease and comorbidities increase with aging, but there are major differences in socioeconomic determinants. People living in poorer areas get chronic diseases 10 years earlier than those living in richer areas. And we need to have a very important impact in all countries in Europe and in the world in order not to have inequalities. However, chronic diseases may start early. And this is the example of asthma in Ontario. In green, you have asthma, in blue, diabetes, and in red, cancer. So we cannot say that chronic diseases are only disease of aging. They may be disease very early in life, and in fact, what we say now, it is that you need to work in pregnancy, for example, to avoid smoking in pregnancy, in order to have less children with chronic respiratory diseases and less children with chronic obstructive patients with chronic obstructive disease later. So this is the philosophy of MAGVIA. The next point I would like to make, it is that, okay, we know that risk factors, comorbidities interact, but how do they really interact at the biology level? And we think that we need systems biology to understand the complexity of chronic diseases. Well, you have here socioeconomic determinants, lifestyle, environmental factors, as you have seen before. They interact with genes and gender. And gender is very important because there are gender inequalities in chronic diseases, which should be better understood. And then you have the biological expression of chronic disease, which may lead or not to a clinical expression of chronic disease and comorbidities. So we need to understand this cycle, which is embedded with age, in order to understand how you can do an integrated care pathway for chronic diseases. Because in fact, this part of the slide is more important because then you need an integrated care for stratified phenotypes, which will lead to health promotion and primary prevention, as well as personalized medicine. And this is what we're trying to do in the different centers of the area in order to better help patients to prevent and manage chronic diseases. Now, I would like to go to our integrated approach to redefine and stratify chronic diseases and how it is applied practically. First of all, this is our project, MACVIA, in French, Contre les maladies chroniques pour un vieillissement actif en Languedoc-Roussillon, in English, Fighting Chronic Diseases for Active and Healthy Aging. This is on the website of the Région, and it is the president of the Région Languedoc-Roussillon who is supporting this project. Well, first of all, we want to redefine chronic diseases. Usually, we are speaking about diabetes, we are speaking about cardiovascular disease or chronic respiratory disease. And then sometimes we assess comorbidities. But how many patients with diabetes are hospitalized due to cardiovascular disease which have not been controlled or prevented? So what we say that we should need a discovery system approach which is based on comorbidities. We need to assess comorbidities when a patient has a chronic disease in order to better control and manage what may be the future. Well, we also proposed a definition of severe disease which is based to a WHO definition which we made in April 2009, and this definition is based on severity. Severity is on one hand associated with control. A patient with hyperglycemia will not be controlled. And then you have the level of treatment. For us, in asthma, the inhalation technique, and for everyone, compliance. And then you have the responsiveness to treatment. What do you need by this? You need to reduce the future risks, that is to say in asthma, asthma exacerbation, lung function loss, and adverse reaction from medications. How can this be approached in two different diseases, which are asthma and diabetes? Number one, underdiagnosis. If a patient is not diagnosed, there is a risk of acute exacerbation in asthma, and most deaths in the UK have been found to be in untreated patients. Or you may have a risk of coma and death due to diabetes. Is there an effective treatment? Yes, there is. Inhaled corticosteroids, beta-2 agonist in asthma, insulin oral drugs in diabetes. If there is no treatment available, like in many developing countries, but also in some of our deprived areas or in some countries, then you have a risk of acute exacerbation, a risk of coma. If you have an incorrect diagnosis, then people are going, if it is, for example, CF, cystic fibrosis in children, it is catastrophic. If it is weight loss due to cancer in diabetes, it is catastrophic. And then you go to the difficult to treat patients, compliance, risk factors, and in diabetes, a complication like the retinopathy. Finally, you are left with two different severities. One, the disease is controlled, but the patient needs a continuous treatment, and you have to focus on treatment continuity. And then you have the patients who are uncontrolled despite treatment. And so we would like to apply this kind of definition to all chronic diseases because it has public health implications. It has also implications for GPs. It has implications for specialists and for the phenotypic assessment of the patients. So how can we do it in practice? Well, in the Montpellier Hospital, we are now assessing all patients with chronic disease by 3 tracks: chronic respiratory diseases, cardiovascular disease, diabetes, metabolic and kidney diseases. They have a common questionnaire, and some specific questionnaire and exams like clinical, biological, ECG, FEV1, pulmonary function test, and echocardiography. And then we're screening comorbidities. There is a second step where assess quality of life, depression, and anxiety, and in patients over 65 years of age, frailty and the risk of fall. We can propose a fall prevention initiative, frailty prevention, or the treatment based on recommendations. But we have a further step, which is the risk assessment and the need for a specialist advice. However, in Montpellier in France, we have a problem with doctors. On the right-hand part of the slide, these are all doctors now. On the left-hand part, on the right-hand part, you have something different, the young doctors. And you see that many parts of France will be yellow and not red in 10 years. This means that we need to bring to the patients a better approach, and this is what we're also doing. We have a mobile clinic which is going into the poverty areas or the deep or the remote areas of the region with the same interoperable clinic. Finally, I would like to finish my presentation to say that we need to assess chronic respiratory or chronic diseases across the life cycle. Well, this is a Polish presidency of the European Union, which was developed by my good friend Bolesław Samolinski, and it was 2 years ago. The title was Prevention and Control of Childhood Asthma and Allergy from Public Health Point of View, and this ended by, this has to reduce or to improve active and healthy aging. So we had also a debate of the European Union at the EU Parliament. This was under the Cyprus presidency and organized by the Région Languedoc-Roussillon. And the title was Impact of Early Diagnosis and Control of Chronic Respiratory Disease on Active and Healthy Aging. And now we are organizing next week a meeting on the role of development determinants of chronic disease and frailty in aging, from science to value creation and policies. And this will be a National Institute of Health meeting supported by DG Sanco, DG Research, DG Connect, and of course, on behalf of the Région Languedoc-Roussillon. So you see, ladies and gentlemen, that we have tried with MACVIA to have systems elements for integrated care in multifactorial chronic disease with comorbidities. First of all, chronic disease represents the global health priority. Secondly, system biology helps to understand the complexity of chronic diseases. Third, there is an integrated approach which is needed to redefine and stratify chronic diseases. And finally, if we want to have an impact, a big impact, chronic disease should be tackled across the lifestyle. Thank you.
Thank you very much. So maybe before I ask a question from the floor, I would like to start with kind of provoking question. Why you decided both to go to this innovation partnership? Can you explain the motivation in the region? You know, when you came to the moment, okay, let's try this new idea with European Union. What was the main motivation for you?
I think the principal motivation was the knowledge that things cannot continue as they are. We need change, and many other parts of Europe are dealing with the same issues, and therefore we knew we could learn from others. But importantly was the issue that I set out at the beginning, was the regional approach within that partnership, rather than participating as a part of a member state. Region to region can really work together.
And John, for you, what was the...
Well, it's very interesting. First of all, we felt that it was a fantastic initiative because then we will learn a lot from others. So I think that cross-fertilization is a fantastic idea. Secondly, we cannot stay where we are, so we need to move. Thirdly, I had two projects. One was the comorbidity clinic, the second was the falls prevention initiative, and they were blocked. So I said, okay, we're going to this, but now we need to go further. And today, the falls prevention initiative has seen around 300 patients, so it's not bad, and it's going across the region very nicely, and the comorbidity clinic is starting to see patients. So on one hand, we cannot stay where we are. On the other hand, we need help, and everyone needs help because, you know. And thirdly, this helped already our patients to move forward.
So maybe last question from my side, and I will ask others. The part of this exercise also was working with stakeholders, with the private partners, with others. So how did you find this part? Because, you know, I think sometimes for public authority it's not easy, even for university to get into this relation.
Yeah, I mean, it has been an interesting, as they say, journey over the past 3 years, particularly with regard to the involvement of private sector companies. And I think a lot of us have experienced being in a room with some academics, some clinicians, and some companies, and all three hearing the same words, but gaining very different understanding. So we're not there yet with all three sectors, we'll say, fully understanding what it is. But we have set out three areas, as I mentioned, and the Innovation Partnership makes it very clear what are the high-level objectives to be achieved. So within that framework, we are learning how to work together.
Well, I think that you make a very nice summary. It's fantastic to work on behalf of this initiative, and I think that the people who are leading it are extremely good, and all, you know, I think I'm indebted with what everyone is doing. I think that this initiative should be better promoted, and I can tell you that the first paper in French is going to be published in a week. So I think that we need to have better publicity across every possible way, and in particular by science publications. And also, it needs to be expanded, because now we are 32 reference sites. Well, we need to have more. And even people who are not, well, 2 years ago there was nothing in Montpellier. And now there is a big project. And it has been almost without any money. Because when I started the project, I said to the president of the region, I'm not asking you money. And this is why I got it.
Good study, you know, just as an anecdote, you know, it's happened at my university that one day one of my rector wanted to produce wine in Krakow, Krakow, South Poland. And so we got help from Montpellier University, and the first department of enology was established at our Faculty of Pharmacy, and believe or not, we produce wine. And this wine is even getting some good prices. But now, not promoting alcohol, it's still early or afternoon, so we go to you. So tell us, you know, who like to take the floor, and Martin, please. The mic, please. Yeah.
Maybe I could link the two presentations. You talked about involving the private sector in some of the responses to chronic diseases, and you talked about, and you gave us the slide of the very high level of multimorbidity in the Lancet paper, which by coincidence I actually showed in Belfast last Friday at a conference there. And one of the challenges we face with an aging population with more chronic diseases in countries like the United Kingdom, and admittedly much less so in Northern Ireland, much more so in England, where the NHS is being privatised, is the drive to bring in private companies to produce disease management programs. And yet all of these disease management programs that are sold are for one disease. The markets hate uncertainty. How are we going to resolve this issue whereby you have private companies coming in to cream skim the easy single conditions, the younger people, and somebody else is left to pick up the multimorbidity? Or is there a way in which the private sector can really make money out of patients with complex multiple diseases without actually charging a fortune for it?
Well, the target of our project is to reduce hospitalizations of people with chronic disease by 20% in 2020. And here, you can make money. So if you convince people that you are going to reduce hospitalizations, then people are going to think, well, it might be interesting.
I guess, Martin, if we had the answer to the question, perhaps we would be in a different business. But for example, the remote telemonitoring, as happens in Northern Ireland, so there's a current contract in place with a number of private sector service providers who deliver a service. And that service is very tightly specified, such that those providers cannot leave some people behind. They've got to deal with all of the patients who meet the eligibility criteria for participation. The negotiation around that particular contract was utterly painful for the people involved. For some people, their careers haven't done too well subsequently. And I think it is an enormous issue that you flagged up.
So if I may ask a question, so I understand the enrollment is everyone who is defined by the social or health service has to be admitted to the program.
Correct.
I have a question for Professor Bousquet. I thank you very much for your presentation. And a couple of months ago, I was in Lyon for a conference on systems medicine. And there were very few public health participants. Now that you have been so gracious to spend 3 days with us, what do you believe is the contribution of the public health community at different scale, epidemiological, organizational, managerial, to systems medicine?
Well, first of all, I am also involved in public health because for 8 years, I was the chair of the WHO Alliance Against Chronic Respiratory Diseases. So I am both a scientist, but I'm always saying that science without public health or public health without science does not satisfy me. So I think that what we need to show, it is that the impact of science will be in public health. And this is what I'm trying to do, and this is my slide. My slide is on the left part, the science. On the right part, it is public health, health promotion, and disease management. So I think that we should say that systems biology without public health doesn't exist. And public health without system biology doesn't exist. So then we can try to get better. By the way, I'm also part of the system biology project of Lyon because I'm leading one of them on system biology in allergic diseases.
Thanks, TGV, it's easy. Any other comments, questions to colleagues in the panel? So please.
So to the question by Professor McKee, a particularity of your case is that at the regional level in France, there is a kind of collaboration established now between health insurance and the regional level of health insurance and the regional level of the Ministry of Health that controls the public hospitals. Do you believe in the old division between the Bismarck systems, the tax systems, and do you believe, or any other in the room, that maybe one of them has any kind of advantage in handling the kind of complexity that came out in your presentation and in your presentation?
The systems should be complex, but the answer should be simple. If you try to reduce hospitalizations by 20%, this is something that everyone will understand, from the payers to the patients to the physicians. So we have made a very simple outcome too, in fact, healthy life years in regions with Jean-Marie Robin, and hospitalization for chronic diseases. And if we can show that, like in asthma, you can reduce hospitalization by X%, in asthma is 80%, then you are going to have an impact, and people and the payers are going to pay. Otherwise, well, what I've said to everyone, it is that I will do the program without money. Because if you start to ask money to do a program, you won't do it.
What is interesting when you have chance to look on this very beautiful brochure, I just have one example, but you can get this on our website. There are all sites one by one, and of course, you know, when you see by numbers, the numbers are dominated from the countries, you know, with the tax-based system. This is Spain, it's Denmark, Italy, UK, Portugal, Sweden, but it's also interesting that still we have one site from Germany, numbers of sites from France, a number of sites from Netherlands, and also one from Czech Republic. So I think it's from let's say from the way innovation partnership is developing. It's also difficult to answer the question. Most probably there's locus loci and also way people would like to bring things together.
Hello, Mark McCarthy. Just to pick up the earlier statement that we need systems science and we need public health science, and we have prevention of chronic disease and we have management and treatment of chronic disease. Would the panel also confirm that we should have equal resources available to both of these activities in the science and the practice at system level?
Of course. You know, I tell you, of course.
Do they exist at the moment?
Sorry?
Do equal resources exist at the moment between the public health sciences and the systems biology?
I didn't make the counts.
Well, I think it's very, Mark, I understand this is also a big question about the competing between medicine, public health, and faculty of medicine, faculty of public health. We are coming from, most of us from public health area, but we also have a chance to work in the medicine field, and we know how it was painful to learn that we are a much smaller brother in the family. But I don't think we can easily find the answer, and I don't simply believe that we will be enriched by funds as a public health very easily. But the numbers of developments, which I think is interesting also in the coming Horizon 2020, one of the cohort studies, and we try to also invest more in this field, so get evidence, you know, for our policies. So let's be optimists, and as I'm born optimist, you know, so I still wish all of you good time before next meeting in Glasgow. And I would like to close this session and thanks my speakers, Jean and Bernadette. Maybe you should go. Thank you very much.